Welcome to Culture Shock Therapy, your health equity prescription. I'm your host, Dr. Katrina Gipson, board-certified emergency medicine physician and health equity thought leader. If this is your first time joining us, I hope it's not your last, but allow me to orient or reorient you to our platform. This is a podcast dedicated to exploring the cultural and political landscapes that shape healthcare inequities and impact our daily lives. So if you're a member of the healthcare field or anyone looking to stay informed on issues impacting how we receive healthcare, you're in the right place. So let's get into it. This summer, I was asked to host a breakout session for the African American Policy Forum's Critical Race Theory Summer School. Now, this year's theme was Freedom Summer 2024, No U-Turn on Social Justice. My session was entitled, Do No Harm? How Colorblind Healthcare Endangers Us All. Before we go any further, allow me to tell you a little bit about the African American Policy Forum. It was co-founded by Professor Kimberly Crenshaw, who serves as their executive director, and Dr. Luke Charles Harris, their deputy director. Professor Crenshaw is founder and executive director of the Center for Intersectionality and Social Policy Studies at Columbia Law School, and she is a Promise Institute professor at UCA Law School. She's popularly known for the development of intersectionality, critical race theory, and the #SayHerName campaign. And she's a host of podcast Intersectionality Matters. Dr. Harris is a former chair of the Department of Political Science at Vassar College, and recently he completed Seeing Race Again, Countering Colorblindness Across the Disciplines, a co-authored edited volume that was released in publication for March of 2019 by the University of California Press. So other faculty that were involved in this year's Critical Race Theory or CRT Summer School included heavy hitters like Michael Eric Dyson, Representative Justin Jones, David Johns, Tim Wise, and K. Wise Whitefield. So your girl was just happy to be there. So check out the African American Policy Forum on their website, support their work and all of the projects that they're doing. It's aapf.org. Once again, it's the African American Policy Forum at aapf.org. So in order to understand the impact of the dangerous notion of colorblind healthcare and the anti-DEI legislation that supports it, let's get into a little bit of terminology, right? Let's have an educated discussion, make sure we're all on the same page. First, let's talk about intersectionality. If you've been listening to other episodes, you know this is a term that I use a lot, but we're going to continue to use it because it's important as it impacts health inequities. So when it comes to intersectionality, what does it mean? It's who you are, how you identify. It's the lens through which you experience your environment and how your environment experiences you. It's your able-bodiedness, your race, your class, your citizenship, your religion, your gender, and even your sexual orientation. For those of you who are new to the platform, I identify as a Black, specifically African American, able-bodied, cisgendered, heterosexual woman, and my pronouns are she and hers. My identities shape how I move through and experience the world, and it certainly shapes how my environment experiences me. So what is colorblind healthcare? So race consciousness serves as a foundation for critical race theory, CRT methodology. So colorblindness minimizes racism as a determinant of outcomes. I'm sure many of you are familiar with the term social determinants of health. We're sharing an image with you that the National Cancer Institute put forth, but we're starting to move a little bit more into the social drivers of health because they feel a little bit less permanent, and it feels like there's something that dynamic that we can actually work to change. So the social determinants or drivers of health include neighborhood and environment, education, employment, and income. What type of schools do you have access to? What type of work are you prepared for after training at that schools? And how much does that work pay? Health and social policies. What about wellness and nutrition? What types of foods do you have access to? Do you live in a food desert, a neighborhood that maybe doesn't have fresh produce, healthy meats, and other choices? What about your race, ethnicity, and gender? And also the type of access that you have to healthcare. So therefore, race and therefore racism is a determinant of health and healthcare and must be acted on as part of a social accountability strategy. Numerous studies show that the social drivers or determinants of health account for anywhere between 33 and 55% of health outcomes, and of greatest importance, they influence health inequities. So racism is a structural system that exists in healthcare, is driven by both conscious and unconscious bias, and it assumes that human value, privileges, and opportunities it assigns human values, privileges, and opportunities to certain groups while oppressing and marginalizing others, which creates barriers to health. So what about DEI legislation? How does anti-DEI legislation support colorblindness and all of the barriers that it places in order for us to address the social drivers of health and other factors that influence healthcare inequities? I'm sure many of you know, particularly if you've been paying attention during, this most recent presidential election and over the last several years, healthcare is the new battleground for anti-DEI attacks and legislation. 65 anti-DEI bills have been introduced since 2023, with 8 of those bills becoming law. So we're going to talk about some of that legislation. First, let's talk about the EDUCATE Act. This was actually introduced by Representative Greg Murphy, who is a physician and urologist in North Carolina. And EDUCATE stands for Embracing Anti-Discrimination, Unbiased Curricula, and Advancing Truth in Education. So what does this act do? It seeks to amend the Higher Education Act of 1965 in order to prohibit graduate medical schools from receiving any type of federal financial assistance, including participating in federal student loan programs, which would, of course, disproportionately impact students of color. And it would prohibit this if schools adopt certain policies and requirements that are relating to DEI. Now, Representative Greg Murphy actually spoke about this act at the American College of Emergency Physicians Leadership and Advocacy Day back in the spring. And from what I was told, there was a lot of interesting discourse to a point where maybe he and some of his fellows and supporters may actually consider either completely withdrawing or at least revamping the EDUCATE Act, which would make it impossible for schools who want to participate in these federal loan programs to have any type of, DEI curriculum. What else is going on? There was a suit against the Medical Board of California aiming to halt Law AB 241, which requires 1 hour of implicit bias training for CME or continuing medical education for its physicians. And it's important to realize that 2 of the plaintiffs, an ophthalmologist, Dr. Azadeh Khatibi, and anesthesiologist, Dr. Marilyn M. Singleton, who recently passed away, condolences to her family and friends, but they, supported this push to repeal AB 241 requiring any type of implicit bias training for the purposes of CME. So take note that these 2 plaintiffs were 2 women of color. So you don't have to be white to be anti-DEI or anti-Black for that matter. And in the words of Zora Neale Hurston, all skin folk ain't kinfolk. And supporters of these types of bills show us that. So what else is going on as far as this anti-DEI legislation that helps to promote this whole notion of colorblindness in healthcare? What about the lawsuit against the HHS? The suit itself is called the State of Mississippi versus Becerra. And in addition to Mississippi, states such as Alabama, Arkansas, Kentucky, Louisiana, Missouri, and Montana led this lawsuit seeking to eliminate anti-racism plans as an eligible improvement activity for the CMS MIPS for healthcare providers. So what does this mean in real terms? With the Affordable Care Act that former President, or my forever President Obama signed into law, we sought to incentivize folks to improve and focus on healthcare outcomes and lower costs, and also incentivize primary care physicians to work in lower resourced areas such as urban areas and rural areas. And in doing so, you wanted ways in which to kind of improve outcomes for these folks. So MIPS is merit-based incentive payment system. And this particular lawsuit sought to eliminate anti-racism plans as eligible improvement activities for the Centers for Medicare and Medicaid Services. So despite the fact that numerous government-related organizations have identified race and ethnicity as social drivers of health, this lawsuit sought to eliminate any type of anti-racism activities that may improve healthcare outcomes and reduce health outcome inequities. Now, you cannot have an anti-DEI talk or a so-called colorblind discussion without the great state of Texas. So let's talk about Texas Senate Bill 17. This actually came into law January 1st of 2024, and it requires public universities to close their DEI offices. It bans any type of mandatory DEI training, and it restricts hiring departments for asking for some sort of, diversity statements where, staff and faculty talk about their commitment to diversity or any work that they've done in the past related to DEI. And so what does this mean? The implications of this are quite far-reaching, as the University of Texas system governs 14 academic and health institutions. So this seeks to impact not just, employees, faculty, and staff, but the patients and citizens and students who these faculty and staff touch. So what about the AAD? The American Academy of Dermatology Association. This is another organization whose members attempted to attack and limit DEI. So what happened? A group of members of the American Academy of Dermatology, or the AAD, proposed a policy resolution to dismantle all the AAD's DEI programs. It's so-called Sunsetting All Diversity, Equity, and Inclusion Programs. It was co-authored by dozens of members who argued that, DEI efforts would possibly be harmful. And this is actually a huge win because in March of this year, the AAD actually rejected this proposal. And not only did they reject it, they took it a step further to make sure that their organization was expanding their DEI efforts. And this is of particular importance because, dermatology is a small and exclusive field, and recognizing disease processes on all skin types, including darker skin types, is paramount, and it can change and save lives. This also may serve to diversify the pipeline into dermatology, therefore, decreasing the number of dermatologists who are more likely to care for persons of color. Well, which states have introduced anti-DEI bills? Well, as of March 2nd of this year, Republican lawmakers in over 30 states have introduced or passed more than 100 bills to either restrict or regulate diversity, equity, and inclusion initiatives in the current legislative session. And this is according to an NBC News analysis. The 3 states that have already, passed these laws include Tennessee, which is where this year's African American Policy Forum's Critical Race Theory Summer School took place. Texas, not shocking. We just talked about Texas Senate Bill 17, and Utah. So how can we solve healthcare inequities through a race-conscious lens? Now, there are multiple disease processes and phenomena with inequitable outcomes due to race. However, for the interest of time, I want to focus on a few topics that are particularly susceptible to the weaponization of colorblindness in healthcare. First, let's talk about gun violence. Black and Hispanic or Latino youth are more than 11 and 2.5 times more likely to die from firearm homicide than their white peers, respectively. So for Blacks, it's 11 times more likely. Hispanic and Latino youth, 2.5 times more likely than their white counterparts. Also, over 45% of Black and Hispanic Latino Americans believe gun violence is an important issue impacting their neighborhood, compared to only 27% of white Americans. Young Black females aged 15 to 34 are over 6 times more likely to be killed by a firearm compared to their white counterparts. So clearly there are inequitable outcomes along the lines of race when it comes to gun violence. Now, gun violence is such a problem in our country due to lax gun laws that there's separate studies and inequities that focus specifically on police gun violence. Black Americans are 2.5 times more likely to be killed by police than white Americans. Black Americans, although we constitute 31% of all deaths in which police officers killed a civilian, despite only constituting about 12% of the population. And between the years of 2019 and 2022, so these were peak pandemic years, the number of fatal police shootings increased by nearly 10%. And in 2022, there were only 15 days without an incident in which police officers shot and killed a civilian. And now keep in mind, these are just about these are only the deaths that we know about, right? So police gun violence is a public health issue. So as a result of gun violence and also police gun violence during most recently pre-pandemic 2019 to 2022 peak pandemic years, U.S. Surgeon General Vivek Murthy declared that firearm violence is a public health issue. So let's marinate on that a bit. Firearm violence is a public health issue in our so-called first world developed country. 54% of Americans, and this is of all race, class, and gender, etc. So over half of the American population states that they or a family member have experienced a firearm-related incident. So let's talk a little bit about reproductive health and the health inequities and color-conscious lens that it requires. Abortion bans are, on the tip of everybody's tongue for those of us who are invested in this legislation in our own healthcare. And, we've discussed this in past episodes, but abortion is healthcare. I'm going to say that again. Abortion is healthcare. It's not just, a political talking point. And unfortunately, on June 24th, 2022, the Supreme Court overturned Roe v. Wade. Now, the implications of this are vast, particularly for certain groups of people. For instance, 54% of Black women, trans, and non-binary people of reproductive age live in states that ban abortion. That's 4.8 million Black women, most living in southern states, where the closest abortion providers are as many as 3 states and several hundreds of miles away. Check out a piece that I just wrote in Visible magazine. It's published in October of 2024. It's called Feminism Owes Us Intersectionality in this year's presidential election. I speak about the implications of intersectionality, feminism, and its impact on abortion rights and reproductive health. What about inequities in maternal health outcomes? Black and American Indian Alaskan Native women are 2 to 3 times more likely to die from pregnancy-related causes than white women. And Black women are twice as likely to experience some sort of serious perinatal complications. And unfortunately, even your degrees, your education, your socioeconomic status cannot save you. For instance, a college-educated Black woman faces a 60% greater risk of maternal death than a white woman with no high school diploma. 60% greater risk. What about this whole idea of colorblindness and the healthcare pipeline? The future healthcare providers, nurses, doctors, respiratory therapists, pharmacists, you name it. Let's talk about colorblindness' impact on physician-patient concordance. Now, physician-patient concordance occurs when the patient and their physician share the same racial, ethnic, or cultural backgrounds, some sort of aspect of their intersectionality they share in common. And studies show that when this concordance occurs, there are better healthcare outcomes. For instance, Blacks make up 12.1% of the population, but only about 5.7% of physicians here in the United States. Hispanics make up about 19% of the population and only 12% of the physician workforce. If you're specifically talking about Black women such as myself, we make up only 2.8% of physicians. So anti-DEI laws that impact public school admissions and hiring processes will negatively impact the already dwindling pipeline of those who are underrepresented in medicine in the medical field. Now, what about diverse teams? So many studies have shown us that diverse teams in healthcare lead to improved outcomes. According to the Commonwealth Fund, and many others, but specifically from the Commonwealth Fund in this aspect, these diverse teams, they improve patients' access to care, they improve patients' perceptions of the care they receive, and it improves patient health outcomes, especially for patients of color. And if you can't appeal, to people's heartstrings, you can always appeal to their pockets. Health disparities are costly. Eliminating racial disparities in health would erase $93 billion in excess medical care costs. And for a country like the United States that already spends the most money on healthcare, almost 20% of our GDP, to have such awful healthcare outcomes, further exacerbated by healthcare inequities, this would be monumental. So what can we conclude from this information? Color-specific health inequities require color-specific solutions. Now, I'm going to say that one more again. Color-specific health inequities require color-specific solutions. Anti-DEI legislation's purpose is to block the tools and resources needed to address health inequities. And diverse healthcare systems and higher learning institutions provide better healthcare outcomes for all people. So make sure that you use your voice and your vote to combat the policies that are seeking to shatter the lens of race-conscious healthcare. So I know that I always, talk about some kind of weighty issues that might feel, defeatist or even depressing, but I'm always going to leave you with your health equity prescription. What can you do with the information that we just talked about? The first thing I'm going to tell you to do is to vote like your life depends on it, because for most of us, it really does. So continue to listen in on Culture Shock Therapy, your health equity prescription. Share with your networks, rate us 5 stars, and until next time, thanks for listening.